Everybody can see those. All right. So as Nick said, my name is Ashley Morgan. I'm the director of the Substance Use Deflection Initiative. We are housed in the Criminal Justice Coordinating Center of Excellence at NEOMED. And thank you so much for allowing me to join you today. I'm, like I said, really excited. So a little bit about my background. I'm a licensed professional clinical counselor with a supervising designation, and I'm a licensed independent chemical dependency counselor. So I've been in the field for about 20 years, started in dual diagnosis residential treatment, have worked in university counseling centers, intensive outpatient settings, research around the implementation of evidence-based practices related to opioid overdose, and now working in the Coordinating Center of Excellence, doing work with deflection. So today, my hope is that we can take a practical look at ways to support people with both substance use and first episode psychosis. And the goal is really to focus on what works to keep people engaged and moving toward recovery. So we know that about half of individuals experiencing first episode psychosis also are using substances, cannabis being the most commonly used. And cannabis is linked to earlier onset, relapse. Alcohol often shows up as well, more often kind of post onset, commonly used as a way to self medicate. So when we're looking at this, substance use here is both a risk factor and a coping strategy. And one of the things that I want us to think about is like when we're seeing use, it's not always about resistance. It's sometimes it's about symptoms, sometimes it's about self management. And it's complicated because substance use itself is a predictor of disengagement from treatment. And it is also influencing other dropout risks like justice involvement, whether or not someone's adhering to treatment or taking medication. It intersects with all of those things and it impacts all of those things. And engagement itself is therapeutic. So everything that we can do to keep someone connected improves outcomes. We can't help people who aren't with us. So when we lose engagement, we lose the opportunity, the therapeutic opportunity. So our first goal is to keep the doors open. And it makes sense that we come from a place of wanting to see abstinence from that abstinence mindset. I mean, we see damages that substance use can do, how it exacerbates psychosis and other symptoms. And we want to protect our clients from further harm. We want to stop people using, and that comes from a place of care and urgency. But the challenge is that when we lead with this abstinence as the expectation for treatment, people who need us most often step away and disengage before we can help them. And it can make recovery less accessible, not more. Abstinence kind of first raises dropout rates, it damages trust, it undermines rapport, it can delay people getting into recovery. I recently heard someone talking about this and said that if our model of treatment only works when someone is not using, then that's not really treatment, that's aftercare, which really resonated with me because in what other disease or disorder do we require that their symptoms are resolved before we can begin care? So the question really becomes, how do we keep people safe and engaged long enough for this change to really start to happen? Readiness for treatment is the strongest predictor of success and change. So our work is really to enhance readiness, not demand it. And we have to meet people where they are and not leave them there and not drag them along with us to where we think they should be. But that doesn't mean that we're endorsing use. It means that we're staying close enough to influence the behavior and the change. So every small step towards safety and stability or insight, those are all evidence of progress in treatment. So everything that we've talked about so far, meeting people where they are, enhancing readiness, supporting the change process, staying engaged even when someone isn't ready, that all has a name, which is harm reduction. And I know that phrase, especially right now, can feel loaded, and people are often associated with like specific things like syringe service programs or naloxone distribution, which are both very vital and evidence-based interventions. But harm reduction is a lot broader, and it's not a philosophy about permissiveness around use. It's a clinical framework that can guide how we engage with people and not whether we approve of their behavior. And it really mirrors some of the core values around coordinated specialty care, these things like autonomy and shared decision making, individualized goals and treatment, collaboration, empathy, dignity, respect. And it's also very recovery oriented. So SAMHSA defines recovery as a process of change. So a process of change, improving health and wellness, living a self-directed life, and striving to reach one's potential. So harm reduction is really how we can keep people safe and connected to treatment long enough for that process of change to happen. And there's like a strong overarching myth related to harm reduction that results in some discomfort around it or maybe objection to it. And that's that harm reduction encourages or enables use. But in reality, and based on literature, we know that it actually acknowledges autonomy and builds safety until readiness increases. And remember that readiness is really the biggest predictor of change and success. It increases the likelihood that someone will enter treatment and achieve abstinence. It reduces negative outcomes, both for individuals and their communities. It reaches people that conventional treatment often can't or doesn't, and it improves provider satisfaction. So not only is it better for the client, but it's better for you. And in reality, harm reduction embodies more than just substance use. Think about condoms and sunscreen and seat belts and helmets and exercise. Those are all harm reduction examples. So we do it every day. So now that we've laid the foundation for what person-centered care looks like in principle, I would like to shift briefly into some of like the models and programs that support people who experience psychosis and use substances. And I'll start with a quick nod to coordinated specialty care, just briefly because you are familiar. So this is that evidence-based, team-based approach for first episode psychosis, integrating care across providers and resources to ensure rapid access and continuity of care. And a lot of the core elements, collaboration, autonomy, setting small achievable goals, focusing on this quality of life, these naturally reflect harm reduction and person-centered principles, even if we're not always using that language. And it also sets the stage for models that maybe more explicitly integrate substance use treatment. And as you guys know, because you're here, the Best Practices in Schizophrenia Treatment Center has excellent tools and resources to help with the implementation of this. Another evidence-based practice that's specific to addressing substance use alongside psychosis is integrated dual disorder treatment. So this is evidence-based, it's stage-driven, motivational, and it's time unlimited, which in practice just means that we aren't discharging someone when relapse happens. We're staying engaged and adjusting to their readiness. Case Western Reserve University's Center for Evidence-Based Practices has training and tools related to this. They have a stage-based decision guideline that I've linked here that matches interventions to the person's stage of change and stage of treatment, kind of looking through that psychosis lens. On the left side of the screen here, you can see kind of a snapshot of that. Maybe it might be too blurry or small for you, but I wanted to show you guys a larger version of that so you can see how it would work or what it would look like. So can you guys see that? Making sure I'm still okay. So you can see over here on the left-hand side, it's the treatment stage, which corresponds to stages of change. So engagement would be pre-contemplation, early motivation would be contemplation, etc. And this walks you through what are some of the things that you should be looking for, what should you be asking, what interventions can be in place. So it's kind of a step-by-step process to help when working with individuals. Another program or project is Can Talk, which is designed for youth and adults with psychosis who use cannabis. It uses a motivational interviewing and stage of change approach to help people explore their use. It has a manual for the clinician and a discussion guide for the client. And really that supports kind of this reflection and insight building and goal setting that go along the stages of change. And then the last thing I want to mention is the community reinforcement approach, which is an evidence-based practice. And while it's not specific to psychosis, it's consistently successful across a range of substance use issues. And I included it here because it gives a solid frameworks for some of the skill building strategies that I'm going to talk about in later slides. The idea is that people are more likely to change when their environment and daily life make recovery feel more rewarding. So it's based on operant conditioning, helping people gradually replace substance use behaviors with pro-social behaviors that feel good to them, that connect them to other people and things in their community. And there are multiple versions of this. So there's an adolescent version, there's an adult version, there's a family training version. So crosses all developmental stages. So the skills and strategies that I'm going to discuss now show up across all of these things that I just talked about, and they're grounded in motivational interviewing. But before we get there, I want to make sure to comment on this. So it's really important that we match our interventions to a person's stage of change because we often lose people when we intervene at the wrong stage. That's where we see resistance come up, and resistance isn't defiance. It's really good information for us. And it's a signal that our approach is mismatched. It tells us that we might be ahead of our clients or that we're imposing our own goals or beliefs. So our task is to adapt and roll with resistance rather than persuade. So we want to become really familiar with the stages of change, what those look like, what the goals are for those, the appropriate interventions, and the signs that you can move on to the next stage of change. So in pre-contemplation, here the person doesn't yet see a problem. There's no intention of change. And the only goal, or the real goal in that, is to build a relationship. Again, there's no plan for change. And success here means you've built rapport and you're creating a safe environment for a person to have an honest conversation with you about their use, even if they see use as still more positive than negative. They see more pros than cons. Those pros can help us understand what's driving behavior, which is information we're going to need down the road when we're doing change planning. But understanding this and knowing it, we're also going to be able to try to start to find motivational hooks that we can connect to, start to develop discrepancy that will help us grow insight in later stages. So interventions here might be managing any acute crisis that's happening, building rapport, learning what's important to the person, assessing readiness to change, completing a functional analysis of use or a functional analysis of prosocial behavior, which means that you're exploring what purpose does the use serve, what else provides that function, are there activities that feel rewarding without use, and you can move on from this stage of change once they've acknowledged that there are some downsides to their use. And I just wanted to briefly show you what a functional analysis looks like. This says for relapse because I couldn't find a use one online, but I will include it in the slides so that you can have it. But this walks through, you're asking someone to paint you a picture of a typical day of use or a specific, maybe their best day using experience. They're painting this picture and you're filling this out along the way, and you're looking at triggers, which one can help you with relapse planning down the road, but also feeds into these short-term positive consequences. What are people liking? What is it getting? What are they getting out of use? Which you can start to see, are there alternatives or things that we can fill in here? How do we address these things? And then the long-term consequences give you an opportunity to look at, like, where can I start developing discrepancies? With contemplation, the person is starting to kind of weigh pros and cons. They're gathering information, but there's no plan for change yet. And so the goal here is really to explore that ambivalence safely, but we're not pushing for a decision. Start to develop discrepancies between their goals and values and their using behaviors. We might want to do interventions here around decisional balance, readiness ruler, and ongoing functional analysis might be helpful. Tools like a values card sort to help people really identify what matters to them and look at that in comparison to whether or not those using behaviors align with what conflict with your values or goals. And you can move on once the person starts to test out new behaviors or decides to act. In preparation, the person intends to change. They start making small steps and they're planning to change in the next 30 days. So the goal here is to support and encourage those change steps. Interventions here might be setting small goals, offering a menu of options about how you can achieve change, offering psychoeducation, the development of a change plan, connecting to supportive resources, and helping your client prioritize the needs. And we really want to meet ambivalence here with curiosity rather than correction because that will preserve engagement. And you can move forward here once the person has set clear goals and priorities for the change behavior. Once we get to action, they're actively changing. We got there. This is where we were trying to get in the first place. So the goal is to reinforce these behaviors and build relapse prevention skills. So interventions would include skill building and practice, maybe role playing around coping, drug refusal skills, communication, problem solving skills. And when I reference community reinforcement approach there, like I said, there's some framework for these specific skills within that approach. We want to build a relapse plan, a relapse prevention plan, or recovery plan. We want to make sure there's connection to things that support recovery. And we really want to affirm the effort that's happening because that supports self-efficacy. And you can move on from this once change has been sustained for 6 months. And then maintenance is the phase where we see that change has been sustained past 6 months. And our goal is ongoing support, problem solving, continued growth. And we want to intervene by reinforcing that self-efficacy ongoing, exploring any kind of emotional or situational barriers, and updating the relapse prevention plan based on that. We want to support the pursuit of meaningful life activities, which means we might revisit that values card sort to see kind of what's meaningful and whether or not we're engaging in behaviors that are purposeful to our values and goals. And so we know also recovery isn't linear. So we have this relapse stage of change. And in this stage, the individual has returned to use after a period of change or abstinence. And this is really common. It's considered part of the process rather than a setback. So it's not a failure. It's data and information that we can incorporate into future planning. So our attitude and perception around it, being non-judgmental, compassionate, can really determine whether someone re-engages or disappears. And it can also determine kind of how they frame it for themselves. So the goal here is to learn from the relapse and re-enter the cycle of change at whatever the appropriate stage of change is. It's often preparation or action. And they are integrating these new insights and strategies. So interventions here are around assessing for crisis, normalizing and encouraging self-compassion, doing a functional analysis of the actual relapse event or series of events, strengthening coping skills, highlighting past successes, increasing support, and then again, updating the recovery plan based on the insights and strategies. And you can move forward with this stage once the person acknowledges the relapse, they've regained motivation, and they're re-engaging and planning for change behavior. So I've linked all of the tools that we talked about here. The only thing I didn't talk about is this knowing your limits for cannabis. It is not specific to psychosis or any other mental health disorder. However, it's really good in setting about reflection along the stages of change. There's some opportunities for assessment and really exploring and testing some things out that I like to use. So to wrap up, harm reduction isn't the opposite of recovery. It's how it starts. It's person-centered and really bridges engagement and recovery. Readiness and not compliance really predict change and success. Meeting people where they are and not leaving them there is the essence of person-centered care. And we have the ability to drive change when we employ these things. And then I have references that you guys can access.